Let us now look at the pros and cons of the other payment models, namely for pay for performance, capitated model, and ACO. So pay for performance is basically attaching financial incentive or disincentive penalty to a payment model that is based on a provider's performance. The pros: there's obviously great focus on quality over quantity. There is more transparency. There is no need to alter payment model structures. Hospitals will be forced to develop strategic targets which are clinical outcomes and patient-related outcomes, not just operational. And there's greater visibility offered by micro-level data. What are the cons? Sounds nice, but it's administratively complex, may not reflect community need. The impact on patient outcomes could be limited because measurement is a problem. There could be challenges with socioeconomically disadvantaged populations, data lag, payments could be delayed because of subjectivity in measurement, and hospitals can game the system through cherry picking or any other methods. Pros and cons of the global payment characteristics of the capitated model. So here, as I mentioned, this is payment based on a predetermined roster of patients. So you get paid even before you deliver service for a predetermined roster of patients that are under your care over a specific duration. So what are the pros? Waste and inefficiency reduction. There's tremendous focus on preventative care because that's how the hospital would make money, by keeping the patient out of the hospital. The payment is predictable both for patients and providers. Administration is simpler. It encourages innovation and care delivery outside of the four walls of the hospital. There's flexibility in balancing the budget, and community is prioritized over individual management. You want to keep the population healthy if you want to be profitable and make money in this model. What are the cons? So the shift in the health profile of populations could impact payments. Hospitals would tend to, there might be a tendency to optimize cost over quality, and health maintenance organizations, HMOs, may limit patient access to providers and facilities outside of their networks. And finally, the Accountable Care Organization, or the ACOs. So as we saw, these are basically organizations or payment models where a group of clinicians, hospitals, and other healthcare providers come together to give coordinated and high-quality care for a designated group of patients. Pros: excellent care coordination, high focus on quality and patient outcomes, technology integration, care is patient-centric, there is focus on waste reduction, and decision-making is shared, and the care is highly coordinated and involves multidisciplinary team meetings to ensure the best outcomes. What are the cons? High administrative complexity. There can be a tendency to restrict referrals from non-ACO providers or providers that are not part of the care organization group. There is a decrease in physician autonomy. There is incentive for volume, doesn't go away. And because of the nature of the coordination, there can be the risk of coding intensity, which also adds to the administrative complexity. This completes the pros and cons of the traditional FFS model and the other emerging alternate payment models.